Good morning. Welcome to our side event at the lucky 8 a.m. slot. So we appreciate your joining us this morning. My name is John Walsh. I'm the Director for Drug Policy at the Washington Office on Latin America, also known as WOLA. And it's our pleasure today to host with the International Drug Policy Consortium, the Center on Drug Policy Evaluation, the Drug Policy Alliance, México Unido contra la Violencia, contra la delincuencia, Canadian Drug Policy Coalition, Transform Drug Policy Foundation, and Échale Cabeza of Colombia. The side event from synthetic drugs, threats to synthetic drug realities, examining the role of global drug policies in charting the way forward. So it's already been an eventful CND with a high-level segment last week, a statement led by Colombia on behalf of 60 countries that pointed towards a transformative phase in UN drug control policy. The end of that statement said, despite the challenging social and political environment that we find ourselves in, let's unite for the benefit of all our people today and tomorrow, starting here and starting now. And we want to start now on the part of civil society to further challenge governments to make good on transforming the UN global drug control system, especially when it comes to the narrative around synthetics. So we'll begin today with Tesha Naidu of the Drug Policy Alliance. We'll then go to Andrzej Sedlinski of the Canadian Association of People Who Use Drugs, who will be joining us virtually. He'll be followed by a video by Maria Gorete Ane of the International Drug Policy Consortium. Then Julian Quintero of Proyecto Échale Cabeza, Colombia, and finishing with Steve Rolls of the Transform Drug Policy Foundation. So we started behind time, so I encourage presenters to go to your main points quickly. Thank you very much. Tisha?
Thank you, John. Can you hear me okay in the back? Okay. Good morning, everyone. My name is Tesha Naidu, and I work at the Drug Policy Alliance. We're a US-based organization advocating for drug policies grounded in science, evidence, health, equity, and human rights. And I'm grateful to be a part of this conversation. My remarks will focus on two main areas. One is to talk about the historical context of the overdose crisis in the United States. And then I will like to conclude by providing some suggestions on what should be prioritized instead as a response. So getting to the first point, there have been distinct waves of the overdose crisis in the US starting in the 1990s when pharmaceutical companies heavily marketed OxyContin as a treatment for chronic pain. And they were misleading claims that the drug was not addictive. And we saw huge numbers of prescriptions that were issued. As a result, there were supply-side tactics that were used to try and stop the number of prescriptions that were issued at the time. And what we saw is that while the volume of the prescriptions decreased, nothing was done to address the opioid dependence, any opioid dependency issues, or untreated pain. What happened was that those who lost access to prescription drugs turned to cheaper, more accessible illicit market alternatives, including heroin. So as heroin use increased, we saw once again supply-side tactics that were prioritized once again. And between 2008 and 2015, we saw heroin seizures quintupling. And once again, sadly and predictably, these supply-side interventions shifted the market. and the demand was met by an even more dangerous drug supply and those that are easily smuggled. By 2014 and onwards, the illicit market drugs became adulterated with synthetic opioids such as fentanyl. What the response was, they were harsh fentanyl penalties. And as a result, we saw fentanyl analogs, which are substances that are similar pharmacologically and chemically, but with slight differences. And so fentanyl analogs flooded the market. And so we had temporary class-wide scheduling of fentanyl analogs. And we're seeing even more substances flooding the market, including xylazine, which is a tranquilizer, new benzodiazepines, and nitazines. Some of these drugs are overtaking certain markets in the US. Unfortunately, these drugs like xylazine and new benzodiazepines do not respond to the opioid overdose reversal medication naloxone. So since 2015, we've seen an enforcement and supply side tactics increase, but at the same time, overdose deaths have been more than doubled. In 2015, at the height of the seizure of heroin, there were 52,000 overdose deaths. By 2022, there were over 110,000 overdose deaths in the United States. The lessons we learn over and over from these waves of the overdose crisis is that when we double down on enforcement and supply side interdiction efforts, we risk creating an even more dangerous drug supply that favors more potent, easily smuggled drugs. These tactics, unfortunately, have not saved lives, but they have made drug use more risky and the overdose crisis worse. And I think we need to make no mistake that this pattern will continue as long as we focus our energy on increased enforcement and supply side interdiction. So some of the solutions that we'd like to propose, I mean, of course, we all agree that the overdose crisis needs immediate action. We need to follow the evidence and prioritize what works. The goal is to save lives, and we need a public health response to fentanyl and synthetic drugs generally. So this includes public education campaigns that teach individuals and community-based organizations and public health workers about the tainted drug supply, the illicit drug supply. We need expanded access to addiction services and social supports, including evidence-based treatment and recovery services. We need easier access to medications like methadone and buprenorphine to treat opioid use disorder. And we need to increase life-saving overdose prevention services, such as greater access to naloxone to reverse overdoses, drug checking services, syringe service programs, and overdose prevention centers or safe drug consumption rooms. So the US-led global coalition on synthetic drugs certainly holds the promise to usher in new approaches, but also the dangers of repeating the mistakes of the past. What we need are public health responses to a public health crisis. And the draft US table resolution here at CND 67 L5 is a welcome step in the right direction, focusing on evidence-based treatment and harm reduction. As more and more states start grappling with synthetic drugs, we need more than lip service to public health and harm reduction approaches. What we need are concrete actions that prioritize health over punishment. Thank you.
Thank you, Tesha, for your admirable clarity and brevity in covering so much material. So now we'll hear from Andrzej Selinsky. Can you hear us?
Yeah, I can hear you fine. Can you hear
Great.
me?
Yep. Thank
Okay,
you.
my name's Andrzej Selinsky. I work for the Canadian Association of People Who Use Drugs and was previously a member of that organization. Um, I'm here to speak on behalf of Canadians who use drugs and folks who use drugs around the world, and to make sure that some of their priorities are discussed and to advocate for what I feel and what many folks feel is needed. what my many of the things situations that my colleagues just the colleague before me just discussed with regard to the situation in the United States it's very similar to Canada. We have 21 to 22 Canadians dying every day from preventable overdose deaths, and we and there have been efforts made in Canada to do programs such as Safe Supply, to implement harm reduction services, needle exchanges, and Canada is on the one hand seen as a leader in the world when it comes to many of these programs, but on the other hand, the unfortunate reality is that these programs are put out as pilot projects and are rolled out in a very incremental manner. Like for example, Safe Supply, while it's a tool that can be very helpful, is something that with the increasing with synthetic drugs and the increased prevalence of xylazine and benzodiazepines and fentanyl analogs in the drug supply, it's increasingly difficult for drugs which are current drugs that are provided for safe supply are primarily morphine and dilaudid or hydromorphone, and they simply for most drug users it's not that's not going to address the benzodiazepines in the drug supply or the xylazine in the drug supply, and it's not going to address the tolerance that's created from fentanyl use. It's unfortunately just a little too little too late. And the other issue is that these programs are presently only have being rolled out in in large, sorry, my cat's hitting my screen, in major major cities across Canada, and are actually in danger of losing funding. And this speaks to my second point. There's also been a backlash to politically to a lot of to safe supply in Canada, and we're grappling with division not only within the harm reduction community at times, but throughout the country. And a lot of safe supply programs, especially in rural areas, have, in Ontario where I live, have closed down. The ones in Toronto are in jeopardy of losing funding or having limited funding and have high staff turnover because of the complexities of addressing these issues. And I think, as was brought up previously, it's really important. Education has to be front and center for this. What a safe supply, making people safe has to be the message that we put forward when it comes to addressing drug toxicity. In other areas, harm reduction practices such as like seatbelts and quality control measures that ensure that our food is safe are the status quo. But when it comes to drugs, the drug supply, drug users have to rely on a precarious supply and have to fight tooth and nail to just try to even get on it a safe supply program. Um, and the methadone program, it can be very difficult. While methadone is available throughout Canada, in most regions of Canada, there's weekly doctor visits, urine drug screening, all kinds of complications that come along with that. And I think we have to realize that there's not a one size fits all solution to this program. It needs to be a multi-pronged approach that includes scaled up access to syringe access programs, scaled up access to safe supply, and public education on a larger scale to alert people to to the fact that scheduling precursors, scheduling all these substances is just going to feed into what my colleague who spoke before was talking about. It's just going to lead to more dangerous drugs, more synthetics, new novel synthetics that are created in pharmaceutical labs, as well as drugs that maybe haven't been around for years, or used for years, such as barbiturates or who knows what. The drug supply has gotten worse and worse. And more dangerous as the years have passed, and as we're trying to play catch up with an incremental approach, it's just not good enough. So, what I really want to emphasize is the importance of creating safety for people who use drugs, because not only do drug users benefit, but society benefits as a whole, by reduced expenditures on healthcare, reduced rates of property crime, a healthier population, increased productivity. It's a win-win situation for everybody to wholeheartedly invest in a safe drug supply. And efforts to do so, I think, should include medicalized models, but where those have been difficult to scale up, I think we have to also look at DULF, the Drug User Liberation Front in Canada, who attempted to provide safe tested drugs to folks in Vancouver, and various models to get people to keep people safe. Thank you very much.
Thank you, Anjay. Again, very, very powerful, succinct, and to emphasize, we need to understand the role of prohibition itself in proliferating new and dangerous substances that are taking over markets and making it so unsafe. We're going to change the order. Instead of going to our video of Maria Gorete, we're going to hear from Julian Quintero. And if I succeed, I will share your presentation as well. Okay, good morning. I don't know speak English. I read my presentation. Okay, from the synthetic drugs to synthetic drugs realities. Despite the consensus endorsement of the global war on drugs by almost every country, the illegal market has adapted to different ways to produce, distribute, and supply drugs. For example, according to the UNODC Early Warning Advisor of the November 2023, 1,230 substances have been reported by governments, laboratories, and partnered organizations. In addition, according to the World Drug Report 2023, synthetic opioids increased for 3% of the total novel psychoactive substance NPS in 2015 to 14% in 2021. The next, please. In the other hand, new drug combinations have appeared in the drugs market, which include NPS, prescription medicine, and traditional narcotic drugs. More than 1 year ago, the UNODC reported to trade of same ketamine-based drug cocktails such as Happy Water in Southeast Asia and 2CV on 2C in South America, North America, and Europe. Next, please. This is okay. Echele Cabeza Drug Checking Service of Colombia has had relevant data about 2C composition. 100 2C samples are analyzed on 2023 by the layer chromatography allowed they contain ketamine, 71% contain MDMA, 39% caffeine, and 70% paracetamol. However, there are other substances that they were detected were identified by the technique. In addition, 25 2C samples were analyzed 2022 by GCMS and were possibly detect oxycodone, phenacetin, some catenones, and benzodiazepine. Next, please. However, the concern about 2C is not only related to component, but also the risk of its popularity in new generation of people who use drugs. We have registered an increase in 2C composition among drug checking users. In 2021, 2C samples represented 70.9% of a sample analyzed. In 2022, 10.5%, and 2023, 12.3%. Regarding consumption pattern, 19% of people who owned a 2C sample reported consuming other substances besides 2C, such as cannabis, MDMA, alcohol, and popper. Moreover, more than 20% of users report daily use. The next, please. And the
The previous finding would not have been possible without people trust in the drug checking service. During more than the years of work, HL Cabeza has received more than 32,000 samples in approximately 200 interventions in 20 cities and those in Colombia. Until 2023, more than 1,000 people have avoided a negative experience or possibility intoxication by receiving a result that did not fit with the substance expected. Our most valuable contribution to people who use drugs is not only the chemical analysis results, but also the specialist advice about the risk in case of consuming the samples. Finally, while harm reduction strategies accept that drug use in a personal decision, the prohibition structure face a frontal war against criminal structures, but data shows that drugs haven't ever disappeared. What will happen with legal substance and prescription medicaments? People need more information to consider consumption high. How many NPAs more will the Commission of Narcotic Drugs decide to place under international control? New manufacturing methods and new possibility to obtain chemical compounds will always be present in the illegal market. Other NPAs will operate wide or without more repressive controls. It is time to ask what the fundamentals are the expanded drug checking service in the different space and geographical region to contain two opioid crises and the NPA's expansions. Beyond needs such and funding, change and public health policies and removing legal barriers per exchange and intervention making to foresee in PUD and lie at the heart of the harm reduction strategy. Each harm reduction program is called the Empowerment the Person User Drugs Community to demand better technology and drug checking and other service with better operation condition. The road is long, but sharing experience across networks can help each of use improve our action to save lives. Thank you.
Thank you so much, Julian. I think your amazing efforts for a decade also show the importance of civil society taking on roles to fill gaps that public policies are not yet filling, and leading the way to saving lives and making drug supplies safe for those who choose to use. Now, bear with me, I'm going to try to share the video of Maria Goretti, and we're still awaiting our final panelist, who is en route, so hopefully Steve Rolls will join us shortly. Thank you.
Important conversation on how prohibition has fueled the increase in use of synthetic drugs, especially also looking at the importance of synthetic drugs, especially when it comes to pain management across the world. So basically my intervention will be looking at some examples from Africa and how the situation looks like, especially the need for us to be more evidence-based with our policies and not rush to increase the strategies that we have always used over the years by emphasizing so much on prohibition, especially because Africa is at the moment at a challenging situation where people are still unable to access the clinical benefits of effective pain management and enjoy the freedom of unnecessary suffering due to the absence of pain medications. Also, we are also at a stage where there's so much outcry by some governments on non-medical use of certain synthetic opiates like tramadol and ketamine, which are the major potent pain management and mostly used in managing post-surgery pain. At the moment, what Africa is experiencing is an urgent need for palliative care with a sharp increased caseloads of cancer and HIV cases. We need a lot of these pain medications. Yet, if you look at the statistics, we are the least in terms of being able to access adequate access to pain medications like morphine. And even if you look at the morphine supply within the health sector chain, it is only accessible in very small hospitals and mostly in urban areas. And so it's very difficult, especially for many within the region, especially governments, to import international controlled substances because they need a lot of authorization. They need authorization from the INCB before they can at least find a reputable pharmaceutical importer to do that. Now, so this is actually fueling the growing inequalities and a large sector of the rural folks that are within that space unable to access these medications and are mostly neglected when it comes to that space. And so these populations, if you look at the situation, will always rely on informal sector, especially the rural poor, to be able to access this medication. Now, what we need to also understand is that, truth be told, most Africans obtain their medications from chemist shops, wandering traders, because they are those that are readily available to respond to the needs of people, especially in areas where the structures are non-existent. And so we'll rely on these chains to supply them for medications to address pain. And so in actual fact, if we want to continue to use prohibition to address these challenges on the ground, what we will effectively be doing is to be criminalizing pain, because and also criminalizing the poor, because they are always bearing the brunt of many of these prohibitionist approaches. Now, what is worrying is that emphasis and more focus on prohibition is actually creating a lucrative criminal market for many of these criminals who are producing very cheap generic pills, which are labeled, especially in Africa, as tramadol. Because in our study in 2019, we realized that a lot of the test purchases that we made on the streets of what was being sold out there and being used was basically strengths that were not the approved strengths that are used within the medical space. And that is why any attempt to have an international scheduling of these substances or restrict this medical use of tramadol will have no real impact on the criminal market. And so we need to be very careful and circumspect in terms of decisions as to what moves we can take to always address challenges when it comes to substances that become problematic in this case. It's an undeniable fact that the world is actually experiencing a worrying trend of non-medical use of synthetic drugs, especially for pain management. But the situation in terms of the problem is that I believe the synthetic drug proliferation is as a result of the spillage of prohibition, because it's more like the balloon effect, where when you pop up, like you press at a balloon, it pops up in another sense. So the more you apply prohibitionist strategies, people would definitely have to find a way of addressing an underlying problem. So for instance, people who are problematic users, once you tighten one area, people will want to look for substitutes that can address the needs and challenges that they are going through. Now, for me, Africa especially, the problem of tramadol is less about a law enforcement situation. What we need to understand is that a lot of the working young populations in the informal sector depend on these medications to be able to relieve themselves of pain. Because in our study in 2018, what we found out was that a number of these young men we interviewed told us that they actually take this to address pain because, for instance, maybe the person is in the construction field as a mason. And so at the close of day, because of the laborious work you undertake, your body aches badly. And so you are looking for these substances to take so that you can address the pain and then be able to work the following day to make ends meet for your family. So in actual fact, if you look at it more practically, these people using these substances are actually addressing pain. It's just that it is not it's not being taken through a due process or through a prescription that is given to them by a medical officer. Now, it is also important to stress that the reactions of countries regarding synthetic opioids like tramadol through a de facto criminalization and increasing restrictions is only going to come at a very high cost onto us because it's going to affect patients and the work of health professionals at the end of the day because they cannot access. And that is what is happening in the case of morphine. You go to many hospitals and this is readily not available for cancer patients to be able to use. So it is critical for us to be more nuanced and factual while responding to the current situation because the addition of most accessible pain medications in Africa will lead to significant damage to the very palliative care system in Africa. And so what this will essentially do that it will fail to address the realities of the issues and it's likely to solve, it is unlikely to solve the problem. So attempts for us to continue to use prohibition or looking at scheduling these substances because they have become a problem will only worsen the situation of non-availability of pain management medications in the region. And of course, the poor will continue to suffer in that pain and will bear the brunt of many of these policies that are being put in place to address the challenges. So for me, repressive response.
Thank you. She had a bit more to say, but we have our last panelist has arrived as well. And in the interest of time, we'll go now to Steve Rolls of Transform Drug Policy Foundation. Thank you, Steve.
Thank you so much, and apologies to John and the other speakers and our sponsors for being late. Don't travel on the metro without a validated ticket. That's the lesson from this morning. Yeah, I wanted to just speak briefly about the sort of UK and European experience and try and position that within some of the debates that have been happening this week and last week at the high level segment, where obviously synthetic opioids were quite a high profile issue. The situation in Europe is really quite different to North America with regards to synthetic opioids. Most of the heroin in North America came from Mexico to the south, whereas in the UK and Europe, 95% of it has historically come from Afghanistan. And as I'm sure many of you know, the Taliban in 2022 imposed a ban on poppy cultivation, which was shockingly effective. Poppy cultivation fell by almost 95%. And heroin production essentially stopped in Afghanistan. Now, there were significant stockpiles from previous bumper harvests, which have filled the gap in opium and heroin production, supplying Europe. But it appears that the constriction on heroin supply to Europe is real, and it may be to some extent permanent or long enough to get beyond the stockpile bridge to the point where heroin supply to Europe contracts significantly. And the obvious risk there is that demand for the effects of opioids doesn't disappear. It will just be met by other sources. In this case, substitution with other drugs, including significantly synthetic opioids, but also probably synthetic benzodiazepines and possibly other drugs as well. Another difference in the dynamic between North America and Europe is that fentanyl hasn't really been anything like a significant part of the illicit opioid market. There has been fentanyl and there have been fentanyl-related deaths, but it seems like, for reasons I don't really understand, rather than fentanyl, we seem to be having a market dominated by nitazines, which is another group of synthetic opioids. I'm sorry if anyone's already spoken about this. It's another group of synthetic opioids, quite similar in many respects to fentanyls, in that they are there's a whole family of different analogues. I think 17 have been identified by the European Monitoring Centre already. They are between 50 and 1,000 times stronger than morphine. So we're dealing with a similar phenomenon. We are very much at the beginning of this journey within Europe. So in the UK at the moment, there are around 2 deaths a week related to nitazines. That number may actually be higher, but they're not being detected because forensics are not testing for nitazines everywhere. But those numbers are rising. There was a police seizure just last November where 150,000 nitazine pills were seized. And I think that shows the scale and potential industrialization of this process. And there is a real fear. I'm very opposed to scaremongering and fearmongering within drug policy, which has been a rather unfortunate element of drug war narratives. But there is a real fear, and I am genuinely afraid that we are at if you look at those horrifying graphs of drug-related deaths in North America, we're at the base of that now, and we could be about to plunge headlong into this catastrophic overdose crisis that has blighted North America over the last 5, 6, 7 years. Our view, Transform's view, my organisation, our view is that we need an emergency public health response across Europe. And you forgive me for not talking about other regions which I have less expertise and understanding of. I think this could easily be a major issue in Africa as well, for example. But certainly in Europe, we need an emergency public health response drawing on lessons from North America. We know what works in terms of emergency harm reduction responses. So I'm talking about things like drug checking services, low threshold access drug checking services, supervised consumption spaces that we've seen across countries across the world. There's more than 200 of these now. They're a very well evidenced intervention. Innovative prescribing practices, sometimes referred to as safer supply, that have been pioneered in Canada. So making things like injectable heroin available on prescription, hydromorphone pills, other forms of opioids, and also stimulants as well, but just focusing on opioids for now. And to underpin all of that, a different approach to law enforcement based on ending the criminalization of people who use drugs to reduce stigma and enable the implementation of those services. And I think what was striking to me about the debates I've witnessed over the last week or so, particularly last week with Secretary Blinken, who was here speaking, Gardia Wally, the executive director of UNODC, was there was a lot of good intention around public health interventions and harm reduction, although Gardia Wally, for some reason, doesn't seem able to say the words harm reduction. Blinken certainly did, and that was very welcome. And then the resolution that's being negotiated this week, I think it's L5, is it? On harm reduction. A lot of this is really welcome, and it shows a sea change in attitudes to this place 5 or 10 years ago when harm reduction was, the words were barely ever muttered at all. It's now being it's being pushed in resolutions, and the US talking about it, and basically everybody's talking about it. The problem for me is this disjuncture with the pragmatism of harm reduction and the public health response and the sort of old school drug war dogma of the enforcement response. So it seems like every time that one of these major figures feels that they want to talk about harm reduction, they also say, and now we're going to have zero tolerance and crack down on supply, and we're going to arrest dealers, and we're going to interrupt, and a load of nonsense about precursors and all of this stuff. Even though the evidence for that is just not there. And it's not just that there's no evidence for supply side interventions when it comes to synthetic opioids. The evidence all reasonably suggests, objectively suggests, that if you enforce against these synthetic opioids, you actually make the problem worse. You create economic incentives for organized crime groups, transnational organized crime groups, to move towards more potent, dangerous, but more easily produced and trafficked products because it works in their economic interest. Why would you bring 50 kilos of heroin across the border when you can bring a matchbox of nitazines or fentanyl? it's just much easier. So I have a deep worry that there is this default towards enforcement responses that don't work, that aren't evidence-based and may actually make things worse. And that clouds the discussions, the welcome discussions around harm reduction and an emergency public health response. And I'm particularly worried that that disjuncture in that conversation that's been happening in this place and in North America is now flowing over into Europe through things like the synthetic opioids task force. And I've probably talked for too long, and apologies if I'm a bit sweaty because I had to run that last bit. Thanks so much. I'll stop there.
Thank you so much, Steve. And I know that we're at time and we'll probably be moved from the room quickly, but since we started late and because there are so many of you who showed up for an 8 a.m. Event, I do want to offer the chance to ask questions of our panelists. And maybe if we do a lightning round and give people a chance to reply, that would be the best way to do it. So if you do have a question, just raise your hand. We'll recognize you, use your mic, and then we'll have all our panelists respond as they choose.
Hello. Thank you very much, Dr. Ben Reyes from the Colombo Plan. As early as 2015, there are already some evidences of adulterants playing a role in the deaths right now in the U.S. I believe capacitating some of our drug laboratories in detecting those adulterants can also support and help the public health component. Any comments on that?
When you say drug laboratories, like, do you mean where these drugs are manufactured by organized crime?
No, the forensic drug laboratories and National Center for Health Laboratories who can help improve
Drug testing
information on
services.
public health interventions.
Oh,
Yeah, I mean, I just on the forensic surveillance, obviously that's really important. The language on that, I think, from all the speakers in the last week have been very clear. We do need really good surveillance. I think the key point I make on that is we need it to inform emergency public health responses and not to justify, militarized enforcement crackdowns, because we just know that doesn't work.
and I just want to add that drug testing in Canada, I think, has changed, has created such opportunities for people who use drugs to just use in a drugs more safely, and just be aware of what's in their supply. Like, can you imagine someone using something from the street and not being able to, having no knowledge of what's in their substance, or it'd be like going to the grocery store and just having like no idea what's in what the ingredients in your food are. So yeah, I think drug testing strategies, as they exist in Canada, is what I can only really speak to. Have been very helpful for people who use drugs, and to the results for the Toronto where I live are released by the Drug Testing Center, the Center for Drug Policy Evaluation, on a monthly basis, and yeah, just really help inform what's going on there, and as trends kind of evolve. So yeah, I think it's a really positive thing.
I'm Nick Boyce with the Canadian Drug Policy Coalition, and I've been deep in the overdose crisis in North America, really since 2017 when we set up an emergency overdose prevention site. I want to just be cautious of the framing around synthetic drugs and talk of fentanyl, because it's not the drugs that are inherently dangerous, it's the unregulated nature of the drugs. When we test samples that people are using that's supposedly fentanyl, you'll sometimes find 3 fentanyl analogs, 2 benzodiazepines, a bunch of caffeine in there. But again, fentanyl is used every single day in human medicine. If you know your dose, if you know the potency, if it's quality controlled, it's not inherently dangerous. So I'm very cautious that we're framing things and it's fentanyl's the problem. It's not, it's the unregulated nature. So I really want to emphasize that piece of it.
Thank you, Nick. We have one more question and then we have 1 minute to wrap.
Thank you. Miguel Bencomo from Mexico. We are in election year. So my question is, what are your recommendations for new congressmen or congresswomen to improve the response of this problem in the Mexico and US border in this specific area? Thank you. Thank you.
I mean, I would recommend that you learn from the lessons from the last 5 decades, that these punitive interventions are completely ineffective. I think the US, and I think one of the other speakers kind of mentioned this, we have a lot of lessons learned about how to implement effective public health approaches. So how can we share lessons with our Mexican public health partners? I know that looking at data that there's a rise of synthetic opioid usage in Mexico. So how can we share lessons about naloxone and early warning systems and drug checking supplies and services? So I would say, let's be a good neighbor to our partners in Mexico and share what we know from a public health perspective, what works. Because rhetoric that's fear-mongering and about militarizing the border is going to do nothing to address the overdose crisis in the United States, and certainly is not going to be helping Mexico. That would be my suggestion.
Hola. Creo que hay que generar todas las condiciones posibles para que exista confianza entre las personas usuarias de drogas y el sistema de salud. Creo que las
So that there should be conditions to generate all the trust possible for people to use drugs to go to the services.
Las nuevas drogas aparecerán o en los usuarios, ya sea en forma de muertos o en forma de reducción de daños. Es como son las personas usuarias las que podrán facilitar a un sistema de salud de confianza nuevas muestras, nuevas drogas para saber qué es lo que está circulando. Eso sería.
So there are 2 ways that new drugs might appear. One will be the tragic one through deaths, and the other one will be if there is trust in the systems, they will appear because people who use drugs will go to the services and provide the samples, and that way you can detect the new drugs.
Thank you, Julian and Isabel, for translating. That will be our final word. So on behalf of the Washington Office on Latin America, all of our wonderful co-sponsors, and especially all of our speakers and our audience, and Anjay in Canada, who has joined us at 3 a.m. his time. Again, thank you for coming. I think we explored a lot. We didn't resolve the tensions that were noted, but we at least brought them more to the surface. So I hope you enjoyed, and feel free to speak to us and our speakers afterwards. So thank you again very much. Bye-bye.